Ben,
and so now I can start recording.
I couldn't hear you.
And congratulations, we are moving. All right, cool. So this is the point where we all can say hi to the live stream because we just had it start. Now I don't know how many viewers we have yet. But I'm going to look at our live stream person and say, hello, live stream. I'm going to wave to you up there. Where are you? You're somewhere up there. And I'm going to wave. How do we wave? What's a slash wave?
Slash wave, yeah.
There we go. Hi, Facebook live stream.
Oh, okay.
So anyway, those of us who just joined on the Facebook live stream, we'll hopefully have some people joining very soon. There we go. I got at least one. This is the first time I've actually had the problem where the Facebook stream just sort of killed itself, like as I was starting to send. So I'm so happy I did their, start sending 20 minutes before you send for the first time, because it clearly didn't work. But that said, we will get started in another, time is it? 6:07. We'll get started with the actual programming in about 8 more minutes. For everyone who's in the audience, half the purpose of this thing is networking, folks. So feel free to get up and actually talk to each other and see who's here and learn a little bit about each other. Those of us who are kind of milling about on stage right now it seems like most of us are presenters, or hosts or coordinators or people who are involved in the event. But in the meantime, feel free to just get up, talk around, talk to people, meet people. I expect we'll have some people coming in on the live stream in a little bit. We'll start hearing some chat from them as well.
It's Matt.
Yeah. What's that?
I said, is this you, Matt? I'm sitting down.
That's the fake.
Somebody's standing there talking to camera, Matt. That is, so that's Kathy. Hey, Kathy.
Hey, Tim, how's it going?
Hey, how you doing, guys? I'm just, I'm liking this one much better than Altspace. This is cool.
Yeah, it's neat. So that camera, Matt. So the Matt who's sitting in the front row, that is Matt sitting in the front row. But he's actually that's the other avatar that I have on a different computer that is doing the live stream. So even though he's sitting there, the view is actually up about 20 feet up in the air, and it's looking at the whole stage. And if you want to see what he's actually seeing, you can just go to the Facebook page, the VRAR Chicago Facebook page, and you'll see on the live stream what he sees. But that said, I'm pretty sure he does hear from that position. So if you're talking right up next to him, he's hearing you pretty loudly.
Yeah. All right. Awesome. Thanks. So yeah, I'm just kind of walking around trying to figure it all out. I'll have my seat, I suppose, but.
Excellent. Hey, there's Francis Wong, who is joined on Facebook. Francis is the guy. It's one of the guys who always used to come in person. So it's awesome to see him. Hello. Nice to see you on Facebook. For those of you who are on Facebook, please, send a comment through and let us know you're there. Say hello, because it's always great to see you guys. So Francis, great to see you again. Hope everything's well. Sorry about the Facebook Live glitches we had. Facebook kind of killed the first stream, so I had to create a second one very quickly. But it's nice to see that you found it and you're back. And we're looking at our Facebook audience is climbing. We're getting lots of eyes out there now, so that's great. I could do the raise hand thing here. We'll have some fun. So how many of you have been here before? Who's been to this event before? You can press the raise hand button at the bottom center of your screen.
Virtually or?
Yeah, virtually or
either.
Merchandise Mart.
Any of you who've ever been to a VRAR Chicago event before? Wow, we got a lot of people in the room and I don't see all of you. That's kind of weird. Is that Anya Jablon? Is that Anya's? Is this Anya that I'm seeing in the list? Anya Jablonowski? Or not? Muted. So.
Hey man,
All
Jacob
right.
Little X. Yeah, I've been here before. Not in this environment, but I've been to
How do I do volume?
your events.
What was that? I heard somebody talking.
Yeah.
All right. So yeah. What we'll do again in a couple of minutes we'll get started. Once we get started, we will. I will probably mute the audience at that point, just so you guys are aware. But in the meantime, you guys can all talk and say hi. I saw you there, Anya. You were talking for a second.
Hey, Matt, can you hear me?
I can.
Quick question. So if we're sitting at a desk and we're far away, is there a way we can enlarge the front screen or the side screens? Other than, we don't want to stand.
Up on the top of your Rubella screen, there should be controls where you should be able to select screen and zoom. The main web screen is the center one, and that's where the majority of the content is going to be. And then the side screens are the other two.
Okay, I see it. Thanks. Appreciate it.
Class.
Sure. What was that?
Magnifying glass.
Yeah. You can also click the magnifying glass over the screen. That's correct.
Excellent. This is a great platform.
It's neat. Hi, Ramita. I just saw that we got Ramita joining from Facebook. That's awesome. We'll get started again in a few minutes. This is, I want to like, Charlie, if you're taking screenshots, you need to come up and get the stage view and do a screenshot from here because it's, we got a full house. It's kind of neat.
All right. Yeah, I got a couple from there. I'll get it now that we have more people. I'll come back up.
Get it figured out, Kathy?
I did. Thanks. Is that Jay speaking?
It is.
Yeah, this is really cool. This one is much better, I think, than AltSpace. And it works on a Mac.
And that is kind of that. You know, when it really came down to what was the deciding factor, that was pretty much it.
Yeah, no, it's great because I have a Dell that I was using with the AltSpace, and it just was not a friendly setup for whatever reason. It might have been my Dell, but still.
All right.
I like the Halloween decorations as well.
What's that? What's that?
Halloween decorations.
Yeah, that was funny, wasn't it?
I just want to say, so Lauren, you know, for the one who's telling everybody else that they didn't put on the Halloween costume, I don't see yours.
Fair.
Oh, burn.
That's fair.
Ow.
I'll take it. I'll take it. Actually, I almost always wear my hair in a ponytail, so I'm wearing a bun. There we go. There's the curveball. Halloween.
That's scary.
okay.
That's definitely scary.
Let's keep it different, I guess. All right, so we're gonna give people a couple more minutes, say hello, grab a seat, get used to the platform. For all of my speakers at this point, if you don't mind, go ahead and try and find your seats. I know Tom kind of sent you guys some assigned seats, I think, or standing spaces.
Tom, you're sitting near my seat.
Primarily Jonathan and Danny, it looks like, are the two who I'm still looking around for.
I'm staring at your back. It's a very nice back.
Sorry, I was trying to take a picture.
Oh,
That's okay. I need to make sure that, hey, Tom, you still got your hand raised from most of it too. There we go. All right, and Charlie is on the stage. It's funny, like I'm watching, I've got like 3 or 4 different feedback loops here. So I'm seeing, you know, I'm watching from a third person from the live stream, but then I have to realize that the Facebook live stream is in fact delayed. So it's like, if I move, I didn't just move.
You're all good, Tim?
All right.
So. I think
Okay, cool. Yeah, I was just checking. I don't know if I'd heard you speak yet, so I just wanted to check in.
I appreciate it. I just got it fixed. All good.
Awesome. I do not see Marco in the space yet, so I'm assuming that I will be doing their intro as well at this point. But we'll see. Hello, Caitlin. I don't know if we've met before, Caitlin. I think we've got somebody new watching on Facebook.
And then Danny, you had seen my the email about seating before and after?
oh yes.
Cool.
Well,
I'm gonna jump off stage since we're about to begin.
And we will. It is 6:15. So with that, I will say officially welcome everybody, both in the Verbella space and in the live stream. Thank you for joining us. As I was kind of, you know, we keep this kind of informal. We keep it a little bit fun, hopefully. This is the VRAR Chicago Next Evolution meetup. Today we're going to be focusing on healthcare as our industry. For those of you who have not been here before, this event is about you, the audience. Both of you, those of you who are in the audience here in this virtual space, as well as those of you who are watching on Facebook. I'm going to mute the audience right now because that'll get things started for us. If you are one of my speakers on stage, please mute yourself if you haven't already. I won't call you out by name immediately. But other than that, the way this event works really quickly is I'm just going to really quickly introduce the topic and thank some of our sponsors. Then each of our presenters is going to come up and they're going to give a very quick presentation about kind of who they are and what they do in their area of expertise. The reason for that is so that you know who is talking and what their areas are, so that if you have questions, you can ask the right person or you can ask across the whole panel. It's entirely up to you. But again, the point of this audience is very much for all of you. It is for whatever need you guys have in terms of immersive technology to be able to take your next step forward. So if you just need to meet the right people who have some development capabilities, or if you need to meet a creative person, or if you're somebody who works in VR and AR and you're trying to meet somebody in the healthcare industry because you think you have a good solution, that's the point of this. So feel free to, when we get back to networking at the end of the event, just talk to the people here. I will definitely point out that we got John Blasek sitting in the front row here from Level X. They are recruiting. They are looking for people right now. So if you're somebody who's in the space and you're looking for a job, see that guy who's standing in the blue shirt in the front row right now. That's why he's here. And I was going to sit back down, but we'll get to that in a second.
I'll sit back down.
Thanks, John. We'll get to that again. I'll shoot another reminder at the end of the event. But I do, again, the point of this event is definitely to connect this community and to get everybody moving forward. Whatever you all need, this community and this organization is here to help you. So please feel free to reach out to us. It's very easy to find our contact information. We're all available on LinkedIn. All the speakers, their contact information is linked from the website. So please feel free to reach out to us. Feel free to connect with us. That's why we're here. We're here to help this community grow and to get people moving and benefiting from this technology, because this technology is really cool. But that said, we would not be able to do it without our sponsors. So I do need to thank our sponsors. And our sponsors for this event are Bundle AR, which I will bring them up in a moment, 1871 Verbella, and on this particular occasion, Matter, which is, but I'll get to them. But Lauren, if you want to join me up at the stage and speak to Bundle AR, I'll get out of the way.
Hello, can everybody hear me okay? Am I good?
Yep.
Thank you, Matt. My name is Lauren Lemieux, and I'm the head of marketing at Bundler. Bundler is an augmented reality platform designed for organizations to create, edit, and access AR experiences in a matter of minutes without having to write a single line of code. That really is the beauty of it. The easy-to-use platform, it really empowers our users to provide these experiential content solutions for today's audience who's hard to capture their attention, as you all know, and have measurable results. We always love the meetup, but are especially excited about the healthcare because of all the benefits this technology brings, whether it's a physician that wants to provide better patient care by augmenting brochures with accurate, trusted information, or a medical device company providing on-demand technical performance training from subject matter experts, the best of the best in the field, or one of my absolute favorites, in lieu of expensive cadavers that may not be readily available, using interactive 3D models to teach incredibly complex subjects and really getting into it. I'm excited to see what we hear tonight. And Matt, do you have the video queued up?
I do, and apologize. Just warning to everybody that when we do play video, we don't have control of the volume individually for how each of you hear it, so it might be loud.
Until now, creating augmented reality was hard. IT departments simply do not have the expertise, so they rely on expensive developers and one-off solutions. Introducing Bundle AR's augmented reality platform. Bundle AR's revolutionary self-serve augmented reality content management system allows anyone, anywhere, to easily create, edit, and deploy augmented reality to Apple and Google devices instantly and on a global scale. Now is the time to add on-demand, accurate, and trusted digital information to your communications through a tool nearly everybody already has, their smartphone. Perfect for just-in-time immersive training, learning, and development programs. Easily place multimedia content like videos or interactive 3D models on real-world items like signage, brochures, or packaging to enhance your audience's understanding of your product, procedures, or story. No special equipment or coding skills necessary. It's augmented reality made easy. Visit bundlear.com now to get started.
Much. So as you saw, it's a lot of fun, and I'm sure we're going to learn a lot more about it tonight. And we've hit some exciting milestones this year and are currently offering free trials to friendlies, if you will. We've recently started that. So if you are interested in trying it out yourself, I will post my email link in the chat and a link to our website in the chat box that you can use to connect with us if you'd like to try it out and create your own AR without having to code. Thank you again to VRAR Chicago for putting on this awesome event we look forward to every month. And if we are live next year, I will wear a Halloween costume to commit or make up for not wearing one tonight. But I'll let you have it back, Matt.
All right, thank you, Lauren. Okay, and so that was 1871. One of our other sponsors, and this is kind of an interesting situation to talk about, but they've still been supporting us throughout, is 1871 is Chicago's technology incubator. There's approximately 400 companies that are located out of 1871 in Chicago. If you're not familiar with the space, you should definitely get familiar with them. Look them up on the web or on LinkedIn, connect with the people there. They still are operating the incubator, even though a lot of people can't be there physically. They've taken a lot of their programming and migrated it to virtual as well. They just held their Momentum Awards earlier this week. Proud to say Wendell Air was actually a finalist for one of the awards, although we did not win. But that said, 1871 is Chicago's technology incubator. There's about 400 companies there, once again, and I would urge anybody who is involved in a tech startup in any way, shape, or form to definitely get connected to that community, because it really is probably one of the best ways to kind of get wired in and have a great place to grow in Chicago. I do believe they're still technically the #1 technology incubator in the world. Aside from, sorry, let me backtrack, 1871, the next sponsor that usually we have somebody from Verbella. Marco, if you're in the room, please jump up really quickly and do this one for me. But Marco from Verbella, which is the platform that we're all sitting in right now. Verbella has been great. The first couple of times that we hosted the virtual event, we did so in Altspace. I know you guys are all aware of that. We did run into some issues there. We had, aside from the fact that people on Macs couldn't join, so anyone on a Mac was limited to joining by Facebook. So we started speaking with Verbella probably about a month or two into us being virtual, and by July we migrated over here, and we liked it so much we've done everyone here since. We actually have VRAR Chicago, the organization, has office space in Verbella, and Verbella liked what we do here so much that they decided to sponsor us for the remainder of the year as well. Which is what, why we have access to this room and why we've had access to the auditorium up until now. And if you want to learn anything more about Verbella, feel free to reach out to me or anybody else on the VRAR Chicago team. We would be happy to connect you with the Verbella team because they're great. We really love this tech. And they're also really great to work with. They're just, very excited to get anything moving forward that they can. Finally, we did have another partner who helped us a lot this time around, and that is Matter. Matter is Chicago's healthcare incubator. They're very much like 1871 for the healthcare industry. Oddly relevant to tonight and tonight's topic. They did, there's at least a couple companies on the stage today who are in fact Matter companies, including I'll let them call themselves out if they want to do that. But Matter's a great spot. It's like 1871. Again, if you're kind of in the healthcare space in Chicago, you should definitely know of Matter and probably be connected with them. I do want to mention again some of the great work that Matter and 1871 have been doing together in response to the COVID pandemic. There's a fund between a lot of the incubators in Chicago related to any products or any companies that are trying to get solutions out there very quick. And that was a combination of Matter and 1871 and a couple of their incubators. They got together to do that. And with that, I will shut up and bring up our first speaker, who is Eric from Level X. So Eric, if you'll join me, I will, as soon as I see you here and you're there, I'm going to go get out of the way and let you take it away. Thank you.
Thanks so much, Matt. I really appreciate it. Hello, everybody. How are you guys? So I'm Eric Gantwerker. I'm from Level X. We actually are one of those Matter companies a long time ago. And so I'll go into a little bit about myself in a second. But essentially, I appreciate all the sponsors and everybody for having us up here. This is a really great event. We've done this a couple years in a row. JP and I were here last year. We're doing some demos. Unfortunately, we're going to have to do videos today instead of the demos. But really excited to be here. And I I thank Matt and Tom and everybody for having us up here. This is excellent. So a little bit more about who I am. So I'm a practicing physician. So I trained as a pediatric otolaryngologist. I'm here in Chicago in academic practice, which I spend about 50% of my time, and then about 50% of my time at Level X. My background was after I finished my medical training, I got a master's in medical education and really had a special focus on educational technology and educational research and the cognitive science of learning, and started getting some jobs in sort of the healthcare education technology space. And one of those companies was Level X way back when, in 2015, when it got started. And so right now I spend my time about 50-50, and I oversee basically all the medical operations of the company. And we'll go into a little bit about more what we do at Level X. Previous slide. There we go. So, one of the things that really got me involved in this space was, I am an educator at heart after getting my master's, but I've always been interested in it. And, the current model for medical education, which I think a lot of people up here are going to talk about, is relatively antiquated. The idea that you sat in a lecture hall and listened still continues to today, almost 100 years later, after a very famous journalist, Abraham Flexner, said that the state of medical education was terrible. And unfortunately, we still have a lot of lectures, including even our continuing medical education, which is sort of our lifelong learning engagement. And the fact that we still sit and passively listen to lectures is still kind of crazy. Today's a little bit different because this is interesting stuff. But, one of the things that we need to move in medical education is from this idea that we can just sit up on stage and people are going to learn a bunch of stuff that are very complicated to more problem solving, trying to give them the opportunity to problem solve. And I think everybody up here is going to be presenting software and technology solutions in the VR/AR space that allow people to do novel problem solving, which is really where a lot of that learning can happen. And we know from the educational literature that people who are active in the process of learning retain a lot more. And the more active you are, and even if you're teaching others, your retention rates go up around 75 to 90%, as opposed to the 20% of you guys sitting here, and unfortunately how a lot of medical education is actually taught. And in the education literature, there's something called Kolb's learning cycle, who talks about experiential learning. And experiential learning is predicated on the fact that you have an experience, you're given an opportunity to reflect on that experience, and then you sort of conceptualize and abstract that to give a deeper understanding, and then you're given the opportunity to actively experiment with that information. And if you miss any point of this, you won't have a deep understanding of that area, and especially in medical education. So, again, a lot of the companies up here are really talking about some of the solutions that they have, giving people the ability to actively experiment, and games is no different, which is where we come in. Another concept for you guys to learn, if you don't know already, is something called deliberate practice. This is the famous 10,000 hour rule, which, you may, whether you believe it or not, there is something to practicing and achieving mastery. In order to achieve mastery, you have to be given the opportunity to have challenging challenges, and to try and develop your skill to meet those challenges. And deliberate practice doesn't mean doing the same thing over and over and over again. It's trying to actually achieve mastery and do better each time, which again, a lot of the technology solutions up here give us opportunity to. But the important thing is that it has to be difficult. If it's not difficult, you're not going to be learning, you're not going to be going forward. And so trying to achieve that desirable difficulty, as we call it, is really part and parcel to how games are actually developed. And we'll talk a little bit more about that. In healthcare education, some of the technology solutions that have evolved over the last 15 years or so involve simulation. And simulation has provided a great safe space for a lot of medical educators and a lot of medical students and trainees throughout their career to really practice things. The problem with it is that although the technology has gotten better, we have higher fidelity simulators that now blink, they give vital signs, they do all kinds of crazy things. They're still physical simulators and oftentimes are locked behind doors. And one of the things that we've realized over the last 20 years is these are great, but what happens if the facilitator is not available? What happens if you want to get in at 10 o'clock at night when you have some free time? You don't have access to those simulators, which is where some of the technology solutions, obviously in the VR and AR space, can really provide a lot of opportunity in healthcare. Nothing more than COVID has shown some of the inefficiencies of being locked behind a door, because all these simulation centers have grinded to a halt, and any education involved in simulation involving these $10,000, $100,000 simulators have grinded to a halt. And so one of the things that we have to look into as a space is software-based solutions. And whether that's on a mobile phone like ours or in VR and AR, those mobile solutions have to be out of the space that is the hospital so that people can actually practice at home. And we need to think very strategically in medical education about moving beyond the walls of the simulations. Moving beyond the walls of the simulation center to really think about software-based solutions. And games have figured this out long ago. Games in the 1980s, you had to go to an arcade to play a game, and they realized that limited access. And when people limited access, it limited adoption. And so they started giving consoles at home, and now you have your consoles in your phone. So you can play anytime, anywhere, when you have free time and you want to play. Games solved this many years ago. A lot of the technology in medical education that you'll be seeing has really been facilitated by our computer's ability to do 3D visualization. And 3D visualization has brought software-based solutions to healthcare and given us opportunities to actually take patient-level data and create three-dimensional renderings that can be manipulated, can be inputted, and actually practiced on in many different spaces, including software-based solutions, as well as 3D printing, which is another big area. And in games, one of the things that has really happened over the last several years, last 20 years, is the idea of computer-generated graphics and the ability for very powerful software to create really realistic scenes. And this is now fusing with the games industry from a technology perspective. You can see the level of detail that actually comes even from a video game like this that's $50 off the shelf. So the level of visual fidelity has come way, way far and now has fused with movies to the point that you can see the level of detail in this character's eye just from the software that made it based on, hundreds of different soldiers on the field in Call of Duty. You can see just the level of detail in one eye and compare that to the level of a simulator in medical education, where basically this is trying to teach eye surgery. So you can see that already from a technology perspective, games offer a lot to the world of healthcare education. And to give you an example, this is actually from our video games. So if you can tell which one's which, the one on the left is actually the real patient. The one on the right is the level X rendering of that. So you can see the level of fidelity just afforded by the technology that's in games. The other that I want to talk about is not just the technology, but actually the psychology of games. And it really goes back to sort of the idea of a flow state and the psychology of games. That's an art and a science. Flow state was described by a psychologist named Mihai Csikszentmihalyi, who was basically watching artists and painters and musicians as they practiced and realized that they got into this time, this area of extreme concentration, intense focus, and they were completely oblivious to everything that was going out around them. And there was a distorted sense of time. And in that space, they were really, truly learning. And games have perfected this, and we're trying to figure out in education how to achieve this. And it's why we'll talk about in a second, you can't just apply this to education easily without understanding the deep psychology. And the way he described how to achieve flow states, and you've all been in this, I'm sure, sometimes it might be playing a game, sometimes it might be doing something really intently, like woodworking or something, or even music or sports. But really, there has to be very clear goals, and there has to be a clear identification of what success and failure is. You have to have clear and immediate feedback on the results of your action, and there has to be a delicate balance of challenge and skills. There's something that's called the 4% rule, which is basically if the challenge is 4% more than your skills, then it will motivate you. And we'll talk a little bit about over challenge and under challenge, but that's a sweet spot that has been identified. But they have to be given the opportunity to adapt their strategy. So trial and error, come back, get a new life, play again. And that is really where games excel at creating these flow states. And basically, games have excelled at creating this relationship between challenge and skill and allowing it to go march hand in hand. As skill got better, challenge gets better. And if you go above the challenge before they have the skill, they get very anxious, they get worried, and they will actually drop out. And games are an opt-in experience. So you don't want people to get frustrated. You want them to get slightly, in the arousal zone so that they're challenged, but you don't want them to get anxious. You also don't want them to get bored. You don't want them to get apathetic. When that happens, they will also bounce out of that experience. And so education has a lot to learn from this area. And if you think back to when you started playing Pac-Man and Super Mario Brothers, there really wasn't a tutorial. There wasn't a lecture before you started Pac-Man. You figured it out by playing it. And as you played it, the challenges got harder and harder, but you learn the rules by playing. You realize that if you hit the ghost when they're red or blue, you're going to die. But if they're flashing, you know that you'll be able to swallow them up and you'll get points. And you learn that by playing. And so again, trying to think about how this applies to education. Really, you have to understand it's a very deep psychology. The way that these games do it is through understanding sociology. They understand psychology. They understand the cognitive science of learning, and they create these things called flow channels and compulsion loops, and they balance reward and frustration in virtual economies, and all of these things that are really interesting, and all those things. So I'm just going to skip forward real quick and show you some of the stuff that we do. Really, we're trying to advance the practice of medicine through play, and try to create experiences from both the healthcare industry and with expertise from the healthcare industry and from the games industry to try and create these experiences. We're in multiple specialties, and I'll show you some videos, especially stuff showing our technology. So Matt, if you could show this video real quick. So in that, you can see some of the obvious technology that we've been using and the psychology we use on the back end, but that was our gastro VRAR, and you can see the fluid dynamics and the soft body physics. If I just want to play one more, if you can skip forward.
Hello?
Yeah, Matt, can you show this one?
Yeah, sure. Sorry, I had a little bit of a lag there. Here we go.
That's okay.
Patient intubation is time sensitive and often tricky. With Airway X, train using a variety of devices and techniques to secure a patient's airway. Simply find the nearest flat surface, and with the tap of a finger, a virtual patient appears. Use AR to first intubate with a traditional Macintosh laryngoscope, then try with McGrath Mac video laryngoscope. Compare your speed, skill, and accuracy in visualizing patient vocal cords. Take intubation to a whole new dimension with Airway X.
Great. If you can go back to our slides, I'm just about done. I just have a couple slides left. Other things that we've done is, so we don't just do procedure based. So this is a mechanism of action game looking at, it's basically a gallery shooting game done in AR. We really focus our experiences. We are mobile first, but we really focus our experiences. If we feel that AR or VR is going to be a value add, then we definitely design for it, but we're mobile first. So a lot of our stuff is mobile. It's free to download, and you can check our stuff out. We, fortunately, with all of our technology that we've been able to create, we did secure a large grant from TRISH, working with NASA. TRISH is the Translational Research Institute for Space Health, and we're working with them to try and figure out anatomical and physiological changes in space, and with the eventual hope of trying to help astronauts work and learn on their way on a deep space mission about how medical procedures can be done in microgravity. Just wanted to give a little plug. JP and Sam and I are going to be around later. We are hiring. We have a ton of open positions. We are based here in Chicago, but obviously with COVID and everything, we are hiring for remote people if they're the right fit. And I really appreciate your guys' time. And thank you so much. Please feel to reach out to me either on LinkedIn or on Twitter. Thanks so much.
All right, and thank you, Eric. That is, as always, really, really, really cool stuff. And you pack a ton of information in a very short amount of time. And with that, so again, just keep in mind, everybody, that the presentations and the videos, because I know he had to skip one, they will be available online on the website on VRAR Chicago after this event. And obviously, everyone's going to be around to keep talking as we go on through the evening. But with that, the next thing I would like to do is bring up Tim Fitzpatrick. So Tim, I should probably look if you want to come up and join me here. All right, cool. I will get out of the way. And let me know when you want to change slides. Thank you.
Will do. Thanks, Matt. All right, hey, everybody. Good to see you. First things first, I just want to say we are also a Matter company, a proud Matter company. We are based in New York, but have had a great experience remotely. I've been lucky enough to make a trip in the past, spend a good amount of time, and was blown away by the healthcare ecosystem out in Chicago. We are virtual, of course, with COVID, but folks kind of spread out all over. Most of my co-founders and I are in New York. So I thought I'd take a few minutes here, start out kind of with my background and path into this space, because I think once we get into questions, if anyone has particular questions around certain applications in healthcare, my experience spans quite a bit of what VR is being used for, though our focus at Icona is a bit more specific. But next slide, please, Matt. All right, this is well, we can go to the next slide, please, Matt. Appreciate it. All right, so talking about my path here, it really starts with my time in the Navy. So I spent 7 years in the U.S. Navy. Ended up spending my final 2 years thereabouts in and out of the VA. Had several back surgeries and I think about 450 wound care treatments over that year and a half to 2 years. So a very painful time, but luckily, fortunately, I did heal. Still a VA patient and still dealing with a lot of that. But I healed, made my way to New York, and kind of changing completely in the industry space. Ended up as a trader, technology and media sector equities trader for a bank in the city. So that was really my first exposure to cutting edge tech, VR, AR, AI, that sort of thing. And it was during that time spent trading and studying how public companies in this case were investing in the future of tech and where those investments were going and which bets they were making on B2B versus consumer adoption. This is an interesting time with the Oculus acquisition, of course. It was around that time that I met my co-founders, and my co-founders were and still are 2 neurosurgeons based in New York who had done a really fascinating randomized controlled trial in the perioperative setting. So really, they were trying to find out what would happen to preoperative anxiety and perioperative satisfaction through the use of a preoperative 5-minute, all right, lost my audio there for a second, 5-minute experience familiarizing patients with surgery. And sure enough, I put the headset on myself and was blown away. I knew immediately it would have changed my life in the Navy and just made so much of what I went through much easier. And that was just kind of the beginning. So I started doing the diligence, realized that was my future. I had to pursue this, and left in March of 2017 to launch Icona and to find out how we could apply VR as an educational tool for patients in the healthcare setting and in particular in hospitals. Now, we have since pivoted. We are a kidney care solution, and that was the product of a relationship early on, about 2.5 years ago. We started working with patients on dialysis. And what we realized is our ability to help patients make informed decisions with VR was far superior than was being seen in traditional learning and education tools. And of course, that evolved over time. We realized that patients were not the only population benefiting from this sort of intervention. And sure enough, COVID came in March, and we suddenly understood that VR was not going to be the end all be all for what we wanted to accomplish. So what we ended up doing is doing a bit of an interesting pivot, and I will be talking about that here in a second. So Matt, slide please. Excellent. So why kidney care is a question we do get pretty frequently, and as I mentioned, it had a lot to do with an early relationship that helped us understand this. But if you put it in large scale numbers, just to give you an idea, about 40 million Americans are estimated today to have kidney disease. That's 1 in 7. But unfortunately, about 90% of those folks have no idea that they have kidney disease until their kidneys crash. They go into kidney failure and they end up on dialysis. Slide, please, Matt. Now, here in Illinois, here I use that loosely, there are 317 dialysis clinics and over 31,000 patients who have what's called end-stage renal disease or kidney failure. Really just an unbelievable number of patients across the country who we work with, who, as I said, they are surprised by this. They end up on dialysis, which, if you're not familiar, involves going to a clinic often 3 or 4 times a week for several hours. It's not a great experience. Patients don't feel great doing it, but they're used to it. It's what they know. So when they're given other options, let's say, for example, doing a treatment at home, it's tough for them to visualize. And again, this is where immersive technologies come in, because you have that opportunity to help patients see what their life might be like in another pathway. So when you're a physician, maybe Eric can attest to this, and he touched on so much of what we love and understand about this technology in his presentation, but the ability to show a patient how it might look will absolutely influence their decision-making abilities, their confidence. And this is what we emphasize, and what we care very much about is understanding what role VR plays, what role AR plays, when that's necessary, when that's the appropriate delivery mechanism. Next slide, please, Matt. Fantastic. So in terms of adapting to COVID, as I mentioned, VR became quite difficult. You have to imagine, if we're working with a vulnerable patient population in a very risk-averse clinical setting, that introducing a virtual reality headset, however powerful it is a risk. And that's important, especially all of us here dealing with this today. That's something we need to be considering. So what we ended up doing is building and shipping non-VR solutions. We got word that we'd have to get creative in March. I think we shipped it by May 1st. We just saw the writing on the wall, and now VR is a critical component of what we do, but it is not everything that we do, because we need to increase access for patients to be able to consume our technology no matter where they are, and as well frontline care professionals who also need access to these tools to have those conversations with patients. Next slide, please, Matt. Fantastic. If you have seen any of our work, and perhaps you haven't, but you'll notice that it falls into this bucket here, this theme. There's a gentleman on my team called Todd Maddox. He academic, spent his career in academia. Neurobiological basis of learning is his specialty, and the systems of the brain and what makes us tick, what makes us learn. And again, Eric touched on quite a bit, but we have broken our system down into 3 components, right? We have 3 steps for every single project that we do, no matter what we're trying to help educate or train in the kidney space. And yes, this will absolutely work no matter what your use case is. You'll probably pick up on a few of these terms here in other presentations, but other chronic diseases, training, surgical training, this applies no matter what your use case is. The first is to identify your learning task. What is it you are trying to accomplish? Familiarizing patients with possible modalities, possible treatments, or is it more motor skills and training, as Danny will speak to here in a few minutes? Second here is identify relevant brain regions. So once you understand what that task is you want someone to understand or learn, you have to know which parts of the brain are responsible for that type of learning. And then find out, finally, which tool will help you engage that part of the brain to accomplish that learning task. And you can do all of this. It's very methodical. It's very systematic. We know what the brain has to offer. It's the same brain we all have, and we know how it learns. So we can essentially choose our delivery mechanism. We can choose our format, whether it is mobile or augmented reality that might be best. You likely, in some cases, will not even need VR for what you're trying to accomplish. So it's important to understand that and to know that. Next slide, please, Matt. Excellent. So quickly here on use cases for us, two buckets. One is for patients and the other is for frontline care professionals. And by the way, an important point here, we started out as a patient education company. When frontline care professionals started picking up the headset and learning the same information, we found that the conversations at the point of care improved drastically, and both populations improved confidence and a number of other learning outcomes that we measure. So we ended up realizing that for every single topic, practically, you'll want to have a variant for both users, the facilitator, and then on either side, where possible, of course. And I'm speaking mostly about nurses, social workers, dietitians. I am not speaking of medical education in this case, just to be clear. For patients, modality education, as I mentioned, transitions. So if a patient makes a decision, they have to prepare to go home and receive treatment, they're going to need some training. And how long does that training typically take? Say it's 6 weeks. Can we get it to 4? Can we get it to 2? Is there any reason why they have to be in a certain location to train? Perhaps not. And then finally, even mindfulness and anxiety, as you've seen so many applications hitting the market, is actually an education and training problem. Quite a fascinating one, actually. And likewise for professionals. So same deal, modality education, confidence building. You want them to be able to answer questions that a patient might have to help build confidence for the patients. And onboarding and upskilling, training a workforce. There's constantly a shortage of employees, and there's constantly a shortage of skill sets. Well, how do we fix that? And how do we give a safe environment for folks to train? And I'm sure that will be discussed here momentarily. Next slide, please, Matt. All right, last thing here for me. Our Learning Hub is a good spot to go to check out any kind of research in this field. Highly encourage you, if you want to know what's being done in this particular area of healthcare, to go ahead and check out our website, find your way to, appreciate that, Eric, to the hub. And this is completely free. We realized early on how key education was. Having conversations with health systems and all kinds of potential stakeholders, it just made it a heck of a lot easier to have a place to send them when they said, how do we know this really works? And well, here's 500 peer-reviewed papers and plenty more on the way. So highly encourage you to check it out and let us know any feedback. We're always adding new ones to the hub. Thanks for your time, everybody.
All right, thank you, Tim. And up next, if we could have, sorry, for a second, I'm looking all over the place, Jonathan. And you're already here, so I'm just going to shut up and let you go. Thank you.
I really appreciate the opportunity to join you guys tonight. Just to give a perspective of who I am. So I'm a neurosurgeon, and I just started up about a month ago at West Virginia University with the Rockefeller Neuroscience Institute. I'm actually on their Eastern campus, which is in Martinsburg, West Virginia, about 2 hours east of the main campus. And so how does that have any relation to what we're doing here tonight? So it's kind of interesting. So I trained to be a neurosurgical oncologist. That means I did residency, and then I did an extra year of oncology up at Memorial Sloan Kettering. And the nice thing about being a neurosurgeon is that we get a lot of toys that help us benefit our patients. So when it comes to new innovation development, a lot of times with neurosurgery, we're the first ones to get access to that. Now, there are a lot of fields that also use it, but when it gets to like navigation, where we can actually tell where tumors are, through 3D renderings and with using such things as virtual and augmented reality, we've been some of the first to be able to have access to that. So to be frank, 5 years ago, I was at GW in DC for 9 years before coming to WVU. I didn't know anything about virtual and augmented reality. I knew a lot about innovation, and I knew that I wanted to help my patients. And I received a note in my box to come to a dinner event, which was a dinner event for Surgical Theater, which is a virtual reality company. So next slide. So, so next slide. And next slide. I went to this dinner event and I learned about surgical theater, and it's a company that, you know, and I've made a point over the time that I've learned about these companies and become involved with development of not to be a consultant, to just work with the companies and see how they can benefit my patients. And it was very clear that this company was originally developed for neurosurgery and you know, allowed using flight simulation technology. And I just had to figure out, you know, a way to bring it to our campus, because you know, we had, from a marketing perspective, we had trouble, you know, building our brand for people to know what we were doing uniquely at GW. From a patient engagement perspective, people didn't really, you know, I used to think that patients understood what I was talking to them about. And from a planning perspective, I always was practicing in my head how to do cases. You know, suddenly I realized, why do I have to do that? And so I started by just going to our surgical simulation center. I said, well, you know, from an education perspective, why wouldn't they want to buy this technology so I can bring it to the hospital? And then you go to, if you've ever been to a surgical simulation center, but I was kind of surprised because, you know, at least at GW and like most centers, it was virtual patients, not in our virtual space like we are tonight, but actual real people pretending to be patients. And, you know, they have these big boxes that were simulations for various different things. And, you know, they had no finances to purchase, you know, a product like the, you know, the company I wanted to work with, nor so did they have a lot of interest. And so eventually I got our hospital to purchase it. And it was very interesting. Suddenly people were really intrigued. And we had a virtual reality technician that came with it. And I wanted to learn everything about the space, what was happening, you know, in medical education, what was happening in different through different innovations. And at the time I linked up with Bob Fine, who many of you may know. He was just starting out with, you know, with developing his platform, and you know, he started the International VR and Healthcare Association. So I linked up with him, and you know, became part of that organization. And I got to speak at his VR and AR healthcare symposium for the last 4 years. And every year it was almost an opportunity to show what we're developing. We started with bringing on this company to help our patients in neurosurgery. I started a working group, and, you know, we started linking with other, you know, with essentially other services that were interested. So if you look online now for thoracic surgery and what COVID looks like in the lung, that's from my colleague Keith Portman over at GW, because I introduced him to this technology, and we brought in colorectal surgery. And so, you know, and the one thing I had trouble with was that when I was there, I could never expand beyond that. You know, when we talk about rehabilitation and pain management, and you know, how do we do that? And from an institute level. And so when I joined WVU, it was such an opportunity to go to the next level with the Rockefeller Neuroscience Institute, where we actually have an XR working group, where we're trying to figure out how we work closely with industry, and how do we educate our understanding how to develop this technology, how to, you know, be end user, which I used to hate that word, but then I kind of realized that I am an end user. And then on top of that, not only do I want to be an end user, I want to take that technology and help that company to figure out the clinical problems I have and do something different with it. So next slide. So as I said, we started with surgical theater, and that was easy, right? You know, the technology was sitting there. I just had to figure out how to maximize its use. And so suddenly we're having symposiums, and you know, every patient is getting access to it when that wasn't really even what they were originally doing with other places. You know, we started doing it in spine surgery. We started educating our residents and our medical students, and you know, and this was great. And I was like, well, how do we go beyond that? So, you know, and it's very easy technology to use. And so what I really realized, to go to the next slide, you know, this is how we used to explain surgery to patients. Next slide. This is a video. So here's me with one of my patients. Can we run the video?
See all the different structures as we're trying to avoid them. So this is the mass. That's the tumor that we were biopsying. Mm-hmm. This pink area is your motor
over to the YouTube
fibers. So that's those highways that we were talking about. Mm-hmm. This is that important. See all the different structures structures as we're trying to avoid them. So this is the mass. That's the tumor that we were biopsying. This pink area is your motor fibers, so that's those highways that we were talking about. This is that important vein that we wanted to avoid that we're going behind. One, it allows us to find spots like this green spot, which is the primary hand motor area. So where your right hand moves, it starts from that spot.
We should be able to see it. It looked like it played in the room for me. Did it not play for you?
Oh, did it play? It just didn't play for me. Did everyone else see it? So that's good.
It was on the side screen.
Yeah. Perfect. Good. Well, the point being is that, so I'm glad you got to see that. So, many patients don't want to wear the headset, by the way. Only about 20% of my patients actually want to wear the headset. So, because it make them dizzy and whatnot. This allowed for a 360 reconstructive image that we could then, I could actually wear the headset and fly through and show patients what we're doing. And so what I realized by doing this, and you go to the next slide. So we took a tumor like this on the left. It's this tiny little tumor. And, this patient was having seizures. And she had one seizure, and a year prior had a little white spot. They didn't know what to do with it. Neurologists didn't know what to do with it. And the patient was from Cleveland, but they were recently had moved to DC. And so they referred him to me as an opinion. And so I'm seeing the patient, and I said, well, maybe we could do something better than looking at this picture on the left. So we did this functional imaging where we can look at the different tracts in the brain and see where the hand and motor areas are. And we created this image on the right, brought her back, and she was originally planning on flying to Cleveland to get this treated. She never went to another opinion. And next slide. And so what we did was we said, all right, how are we going to get to this safely? And so I can show the patient that, but I can plan for it too. So I'm not just doing this on my own, saying I'm just going to teach my residents. The patient actually gets a better feel for things. So if you look on the two dots in the middle slide, there's a dot on the left and the right. One's trajectory, one's trajectory 2. I wanted to go through the long axis of this tumor. How can I do that? The two-dimensional images, I just wasn't sure if I was missing a vein as well as I could otherwise see. I didn't want to go through a valley, the sulcus of the brain. I wanted to go through its gyrus, and that's why I mapped that out. Next slide. And so, so this is the small incision that we made. It was at a very sharp angle. And next slide. And this is what we went up to. Let's do the next video.
Really been very healthy my whole life. So to have words like tumor applied to something in my body, it's pretty shocking and frightening.
There was just a lot of uncertainty, and that uncertainty made me very fearful, very frightened.
Our internist said, you need to go get an MRI, and she referred me to a neurologist.
Marilyn only had one sign, which was a seizure. She had been put on anti-seizure medicines by a neurologist up in Maryland, had imaging that showed a small lesion that they weren't sure what it was. The final diagnosis was a WHO grade 3 astrocytoma. What that means, it's a moderately fast-growing primary brain tumor. During the first appointment with Marilyn and her husband, they were definitely nervous.
It was clear from the moment he walked in the room that he was exactly who had been delivered into our life. He's extraordinary.
The plan was to do a biopsy, and now the question was, can we safely do that without causing harm? Let's put our headsets on and we can fly you through your own brain. In my opinion, the virtual reality 360-degree system was pivotal to planning Marilyn's case. What we're going to do now is fly into the brain. It uses flight simulation technology that no one's really used before. So this is the mass. That's the tumor that we were biopsying. The surgical theater 360-degree VR technology allowed me to better explain to Marilyn her condition during the consultation. It allowed me to show her her brain and show her where this mass was and how we would get there safely. We're giving like a mini anatomy lesson, and it's just another way of getting a patient comfortable with the fact that they're going to have to undergo a major surgical procedure.
If I'd had any stress about it before, it was gone.
The good news from how we planned this surgery was we removed greater than 80, perhaps even 90% of this mass. We sent it to her pathologist. In the operating room, she went to the ICU. Everything looked fine on a post-op CAT scan. She went home the next day.
I was overjoyed.
I'm absolutely certain that the only way he was able to do this resection and get 80 to 90% of the tumor out was because of the mapping exercise that he was able to go through to get to the right place in the brain safely with the technology. I feel so strongly about it that I think that it should become a standard of care for people who have brain tumors.
She's doing very well. She's excited about getting back to life, and she's experiencing life right now. I'm excited for the future that she has.
I just remember having a feeling of overwhelming gratitude. I felt like I was in the right place at the right time.
We couldn't have asked for anything more.
So next slide. So so you can see there's a lot of value in this, and this is what, so we're doing this. We're educating patients. So that was when I was at GW, and now we've transitioned all this to WVU. And the question is, can we do more? I mean, we're introducing this to our patients, and that's great. And that's the most important thing as a clinician, that I need to be there for my patients. But what about how utilizing this technology across the campus? So next slide. So we're calling this a healthcare initiative, but it's through an innovations initiative through the Rockefeller Neuroscience Institute, where we're really utilizing VR and AR and MR, in fact, to connect and improve medical education, patient care, telemedicine for things that we have to deal with the COVID, community outreach. Next slide. So medical education. Next slide. So for a VR anatomy platform, students have trouble in the COVID era getting into the classroom, and cadavers are tough to get now. And so next slide. There's a company called 3D Organon that we linked with, and we said, all right, let's bring them on campus and let's have students have a better experience with a virtual cadaver. And so this is something that we worked on, and we had started a pilot program when I was at GW, and now transitioned to WVU with the same interest, saying, can we include this into our medical education? Next slide. And when you look, the future of VR and AR programs, I mean, you have a whole dynamic program that could be integrated, not in exclusive in the VR AR world, but it can be integrated with this technology to help education. Next slide. And then patient education. Next slide. We can go beyond virtual reality for the neurosurgery. Innovations for, there's so many companies out there for acute rehab and pain management and chronic pain. And so working, this was a company that I was working with us at GW, VR Health, to bring that technology. It's one company of many. Next slide. And they have these technologies, but there's Behave VR, there's MindMaze, there's so many companies that I've, through my interactions with Bob Fine and being part of his network, meet these companies. And go to the next slide, please. And then we talk about telemedicine. So I'm working with engineers to develop, a virtual reality decompressive surgical procedure for trauma, for training, that can be linked to the DoD. Next slide. So in combat, there's always problems with getting experienced neurosurgeons. Next slide. And with that, you need to be able to remove the bone so the brain can swell very quickly. And how do you train general surgeons in the combat field? So we're actually resubmitting an R01 grant through the NIH to develop a simulator like this, where you could train that. It's a low cost. You don't have to have a cadaver. You don't have to be in the operating room with a patient necessarily. You could be virtually with a neurosurgeon learning this procedure, and you can do it simultaneously. So we're doing this. There's many companies, some great companies, including PRECISIONOS here today, and other companies that are doing this, and we'd like to link with those. Next slide. And also community outreach. At GW, we're combining neurosurgery and thoracic surgery for high school student engagement. So there's lots of ways to get the word out. Next slide. So our strategic goals are to develop an infrastructure for the institutes, most notably the Rockefeller Neuroscience Institute. We want a seamless IT infrastructure, and we're working on that. But we have to, and we're working on establishing key personnel to serve as the development of this collaboration across the WVU campus. But when we're talking about this, we're developing a strategy for funding collaborative projects. And with industry sectors, that's the biggest challenge. I've met great companies, and that we would love to work with over the next couple of years. And we're looking at companies that already have end user products that we can develop new products with, and also products that don't have a good solution right now, that we have, companies that have base, production software development that will allow us to get to where we need to get to. And so we're excited to be a part of this. And if anyone wants to reach out to us, reach out to me. We'd love to, have a conversation with you to help get to the next level. So work with these collaborators, such as our innovators at the campus level, but also in industry, to really push the field of healthcare innovation. So we're open to working with any company. We're still just meeting and greeting at this point. We're working on all these different strategic goals, and I'm certainly available. I've gone over my time, but I greatly appreciate the opportunity to talk tonight. And happy to talk with anyone, as the days go on, and as we have new opportunities to connect. So next slide. That's it. Thank you.
And thank you. And to be clear, I want to make one thing clear to our audience, both on Facebook and again in the room here. Whereas as an event, we've asked a lot of these guys to basically, hey, take a 45-minute presentation and cram it into 7 minutes. So it is really hard for them. I do want to thank you guys. I know we're rushing you and you're trying to get out a ton of information. But the other thing I do want to, I definitely absolutely want to emphasize here, and this is one of the things that I want everybody in the audience here, watching the live stream, or honestly, even if you just end up watching the recording of this in the future, this is a starting point for a conversation. Like, these presentations will be available online. These people are easy to reach. Connect with them after the event and make this a longer conversation. If you want to learn more about what's going on in the space, the whole point of us being here is to connect in person and meet these people and talk and start these conversations and move forward with work and with using the technology. And so, myself and everybody else here, that's why we're here. We want you guys to reach out to us, to connect with us, to, have actual reasons to work with us. It looks like, Mike, I can't tell, are you like standing waiting for a handshake? Is that what that does? I got to figure out how to do that. No. But with that, is it like shake? I'm not sure what the command is here. With that, I will bring up Mike Wesolowski from Luxonic. And here, I'll try, is it this? Yeah, I'm sort of standing like that. But we gotta be closer? Okay, let's see here. I'll try one more time, and then we'll get going. Did that work that time?
Hey, there we go.
All right, I'm gonna go, I will shut up now and go stand off to the side and let you get going. Go ahead, thanks.
Great. Thanks, Matt. Hi, everyone. Thanks for being here, joining us at this event, and thank you to the VRAR Chicago for organizing the event. It's our first time presenting here, and it's been great so far, and I look forward to future events. So my name is Mike Wesolowski. I'm the CEO and co-founder of Luxonic. And we are also a matter company. We're an international matter company. We're based in Canada. And as a quick introduction to my background, I've got a PhD in physics from the University of Waterloo in Ontario. And I completed my postdoctoral fellowship in medical imaging at the University of Saskatchewan. My work during my postdoc focused mainly on integration of new technologies and development of new technologies into medical imaging. So worked on things like, developing new methodologies for the assessment of kidney function using nuclear medicine, developing new X-ray technologies, and really figuring out how to best integrate those into medical imaging workflows. I'm currently a part-time adjunct professor in medical imaging at the U of S and have previously held management positions in innovation and technology within the public sector. I started Luxonic back in 2014, sort of working off the side of my desk during my postdoc, and became the full-time CEO in the company in 2017, and we've been going pretty quickly since then, focusing on really solving big problems in healthcare and medicine, and we have really focused on using immersive technologies to solve these big challenges. Next slide, please, Matt. So to give you an example of what we're sort of talking about, around the world, we spend about $500 billion on radiology services every year. We generate about 3.6 billion medical images, and those images are reviewed by about 120,000 radiologists. But for all of those resources and all of the money that we're pouring into medical imaging, 5 billion people around the world still don't have access to basic X-ray and ultrasound. If we were able to solve that problem, we could resolve about 70 to 80% of all diagnostic problems globally, and we could really improve access to basic radiology services. So how can we actually help solve that problem using immersive technologies? Next slide, please, Matt. So, it turns out one of the biggest rate limiting factors for, preventing the scaling of digital medical imaging around the world is the radiology reading room. So this is where radiologists spend most of their day. If you've ever gone to get an X-ray or an MRI or an ultrasound, once that image is captured, that digital data is sent to a reading room for the radiologist to review. That reading room can contain, multiple diagnostic monitors, a workstation, communication devices, a medical library, and a whole lot of software that sort of ties it all together. It's typically fixed infrastructure. It takes up a lot of space. It can cost $30,000 or more to set up one of these rooms. So to really improve the reading room and to increase access to diagnostic imaging services, we have taken the whole concept of the reading room, everything in it, and we've virtualized it. Next slide, please, Matt. So we created what we call CVERT. CVERT is this entire reading room in a VR headset. We've made the system collaborative. It integrates with all other existing sort of digital imaging infrastructure. So everything from, mobile X-ray and ultrasound devices through to your picture archiving communication systems, which store those images, along with all of the software that you need to actually be a radiologist and work as a radiologist on a day-to-day, in day-to-day practice. So the benefit of this workflow is it's the same workflow you would get in a hospital, but you can take it anywhere with you in a VR headset. So this is going to allow us to really scale that last piece of the digital imaging puzzle, which hasn't been scalable before. And Matt, maybe we can play the video. This will give you an idea of sort of CVERT and the system that we've built so far. Thanks, Matt. So, unlike some of the other talks today, Sievert is really focused on replicating the diagnostic workflow in radiology. So with Sievert, a lot of the work that we've been doing has been into creating that diagnostic workflow and really mimicking that workflow as best as we can so that we can slowly introduce this concept into radiology. And then as we continue to integrate our systems, then we can start taking better and more advantage of some of the unique things that we can do in virtual reality, like being able to reach out and grab an MRI or a CT scan and do a dive into patient data. That being said, we do some work in medical education and training. So next slide, please, Matt. If anyone's interested in having a conversation about some of the other work that we do, I did try and keep this as brief as possible. So if anyone is interested in talking to me afterwards, I'd love to chat about some of the other work that we're doing. But really, our main focus now is to get approval for Sievert for diagnostic work. We are working with Health Canada to actually get accelerated approval for using Sievert for COVID diagnostics, and we'll be applying for a 510(k) approval in the US soon. We're doing research trials sort of around both the US and Canada using Sievert. And even, there are some applications for Sievert, in medical education, especially using our collaborative sort of VR medical imaging space, where we can put physicians and students in the same virtual space while keeping physical distancing. So I'm going to leave it there. Appreciate everyone's time and look forward to answering questions and speaking with folks during the networking session. Thank you.
All right, and thank you, Matt. Okay, so Mike, you got a little bit more time. Can you go into like 2 seconds about what you did with the Canadian Space Agency?
Yes, I can. So we have been working with the Canadian Space Agency to develop a medical training system for deep space missions. So we have been working on the project for 1.5 years now, and we're going to be presenting our pilot to the Canadian Space Agency in March. But the whole idea here is, virtual reality technologies are very portable. They're low mass and low volume. And if you're trying to put something into space, if you want astronauts to be going to Mars, for example, you need to have a system in place which allows them to continue to train or upkeep their basic skills. And so, we've been working with the Canadian Space Agency on a project that will allow future astronauts to be able to do that. The low mass, low volume thing is really important because if you want to send 1 pound into space, I think it's something like, $30,000. So even a monitor, which can weigh, 6 or 7 pounds, surgical equipment, training equipment, just it makes a lot of sense to virtualize that entire system so that you can do training. With using very little resources. So,
thanks. Sorry to throw you on the spot there and hit you on that one, but when Mike and I first met, the first thing I see that he presents to me is he's showing us these. I think she was actually a doctor, but she was in like one of those airplanes that does the zero-G stuff, wearing a VR headset. He's like, "Yeah, this is what we're working on. It's really cool." But anyway, so it's just a really neat story. So Mike's contact information is up on the screen. It's also going to be available at the website. And with that, I need to introduce our last speaker for the evening, who is Danny Goel. And I apologize if I'm butchering your name, sir. But you're here, so I will just let you go and shut up, and we'll all be back for the Q&A after this.
Great, thank you very much, Tom and Matt. I want to thank VRAR Chicago, obviously, for having us, give us the opportunity to speak. This is our first time as well here. I also want to thank my co-panelists for some wonderful presentations ahead of this one. So what I'm going to do is I'll give you a little background about myself as a brief introduction. So my name's Danny Goel. I'm an orthopedic surgeon in Vancouver, Canada, clinical associate professor at the University of British Columbia, Department of Orthopedics. My role there is I work as a consultant shoulder surgeon. So my primary interest is in shoulder reconstruction. Part of my responsibility at the university is I also get the opportunity and privilege to teach residents as well as do courses around different parts of the world, or it historically did prior to COVID. The opportunity to teach and train other surgeons as part of societies that I am affiliated with, as well as some organizations. And about 3 years ago now, the real interest in patient access to care, and I think John mentioned this as well, as that's where the motivation for this originally started, was how do you provide the best access to the patients in a very timely way. And in Canada, that was suffering a little bit, at least. Seems to be a national problem, because physicians typically refer patients to specialists. They don't just get to see a specialist on their own. They get screened by the family doctor, who then refers them to a specialist like myself, and then they may have to wait in line behind the other patients who have to be seen. So to look at a way to expedite that process, I met one of our co-founders, Rob, who was in game development, who introduced me to our other co-founder, Colin, who also happened to be in game development, and they introduced me to this technology that we're all here about, which is virtual reality. And the first time I put that headset on, it certainly wowed me. And I'll talk about where we've gone from that initial meeting, which was effectively a random chance, to today. Matt, next slide, and I can control it too if that opportunity exists. So I'm going to talk a little bit about surgical education in 2020 and insights that we've seen using immersive technologies. Next slide, please. Disclosure as noted. Next slide, please. So the problem with surgical education, I think this was alluded to earlier by Eric, which is certainly very true, is if you're going to practice and perform in the same environment, which is in our case as surgeons in the operating room, that doesn't pose a very interesting value proposition for the patients. And when we train our residents and trainees, we need to offer them an opportunity to make a mistake. And that opportunity doesn't exist in our current model. And the reason it doesn't exist is because when you fail, you need to understand the consequence of your decision, which actually impacts how much you retain and learn. So that environment currently does not exist. Next slide, please. Now, on the left side, we could talk about what we need to teach, and this idea of we know exactly the content we need to teach. And I put here specialties like orthopedics, general surgery, et cetera. But the idea of how we need to teach is this concept referred to as metacognition, where we use this approach of lectures, video, and as was previously mentioned, cadavers and perhaps sawbones. But the reality is, none of those actually speak to this idea of what I'll refer to, and has been referred to, as productive failure. Next slide, please. So this was also mentioned earlier. This is the famous bar graph by Ebbinghaus. Hermann Ebbinghaus described how non-experiential retention is actually very, very poor. So most of what I tell you today, you will forget in approximately 6 days. And that's a testament to the type of learning that we do engage in. Now, I'm not stating that this is not important. It does pose a specific challenge in the era of significant webinars right now, but I'll talk about how this is important in combination with other types of education referred to as synchronous learning. Next slide, please. So areas that are absent in healthcare right now are these sort of core principles that we can discuss in detail. But distributed learning is, if I'm going to practice a skill, and I'll use sports as an example, I want to be able to practice that skill over time. The second idea is interleaving, and I use another sports analogy, which is tennis, a variation in skill. So when you're practicing tennis, you want to practice not just an overhand, but a backhand, a forehand, etc. And then the last idea, which was mentioned earlier by Eric, is this idea of deliberate practice, which you have an immersive environment, which gives you data on your performance. It allows you to fail, but importantly, it allows you to repeat that performance. And it's not shocking to hear that most of these core principles of education are actually absent in our healthcare educational paradigm right now. Next slide, please. So here's an example of a surgeon in position A and a resident or a fellow, or perhaps another surgeon in position B. The one thing I know certainly as the surgeon is likely actively engaged. She or he would be actively involved in this patient's care. The person in position B, I have no idea when I'm in the OR with a resident or a trainee if they're actively engaged or thinking about what they have to do this evening or tomorrow morning. And that's referred to as passive engagement. One of the things that we're certainly victim to is when I'm in the operating room with a resident and I see them struggle, is I will put a retractor or help improve their visualization of the particular case to help them progress. And what I've done there is actually disabled their thinking, because I can't allow them to struggle for a long time, because that would be poor patient care. So you can see how where I'm going with this when it comes to learning an environment that actually allows you to be fully engaged and make a mistake and learn from that. Next slide, please. So here's a video, and I think we'll be able to show this, Tom or Matt, if you want, but this is a video I embedded in the presentation, but we could perhaps go to the YouTube video now if you like. So what this is showing is we use the portable solution, which is the Oculus Quest, and it's probably a little bit loud there to hear, but maybe I'll describe it after the video is over. So I'll comment on a few things from that video. Thank you for showing that, Matt and Tom. So one of the things that we wanted to avoid doing was to digitize our current model of learning. So we didn't want to take our current existing way that we teach surgery in this case and just place that into VR. What we wanted to do and what we found to be valuable is to help close the gaps of knowledge. So for example, you saw that fracture being reduced and put under traction, manipulated. Now, as learners, we don't really get the opportunity to see how a fracture would behave under X-ray when you do manipulate it. And what that's speaking to is when we think about cases and we look at X-rays as surgeons or physicians in general, is that we are creating mental models in our mind. And those mental models are based on experience, they're based on volume, but they're never based on an opportunity to actually see what you can do and convert a 3D image from 2D immediately in space. And that's what we've tried to do there. The other thing those videos do showcase is the idea of productive failure. So we allow you to do most things that are critical, which actually have direct impacts to patient outcomes. So if you malrotate a particular component for a patient's knee replacement, that outcome will be poor. The other thing that we've shown there is the idea of arthroscopy. So when you put cameras into joints, that's referred to as arthroscopic surgery. And that's a really challenging thing to teach. And especially when you teach it in the context of a patient, and I'll use a hip scope as an example, which is a very becoming a common procedure now. There's a patient attached to when you put a scope into a hip, and it sounds a little bit, silly, but when you actually have to do that procedure, you actually have to put the leg under tension. And unless you're being mindful of that, this whole task training idea, you can actually have a unassociated complication unrelated to your surgery, and that would be an injury to a nerve because the leg was on tension for too long. These are the kind of things that we're really interested in. Next slide, please. And so one of the things that we've tried to do, being a researcher myself, is we took a very, very academic approach to this. And for time's sake, I just summarized some of the randomized controlled trials we did, but we just completed a second randomized controlled trial with the Shoulder Elbow Society in Canada. And the reason we did it in collaboration with them is we wanted to mitigate bias in its entirety upon the evaluation of the trainees. So to give you a high-level overview, we randomized 2 groups of senior residents. These are 4th and 5th year residents to 2 groups. The first one would be to VR, and the second group would be to traditional learning, which would be reading. And the second study we did was comparing it to video learning, which is a very common technique that we use when learning either a new or reinforcing an old procedure. And then once they had that learning environment and learning intervention, we took them all and they went to the cadaver lab. In the first randomized controlled trial, it was very clear from a technical standpoint, when the society members evaluated the residents, not knowing what type of intervention they had, the VR group outperformed the non-VR group. In the second study, what we did was a little bit unique, is we actually created an abnormality in the cadaver, because as the physicians in the audience will tell you, you never operate on a normal patient, and yet cadavers are naturally normal by most intents and purposes. Their anatomy is not pathologic. So we actually created an abnormality in the scapula in this case, and wanted to see if the residents could actually recognize the abnormality as well as reconstruct the shoulder like they would in real context. So we wanted to make it very patient and relevant to what they would see in real life. And what we found was from a technical standpoint, the residents were much more superior from a technical standpoint in the VR group. But what was actually the most interesting finding, which I didn't add here in the interest of time, is the VR group actually made 50% less surgical errors than the non-VR group, which speaks to a deeper idea of knowledge and conceptual and three-dimensional learning that they would have received in the VR environment. The last 2 points on this, that the cost is something that we can talk about in detail. But what we did calculate here, which is a common term used in simulation, which is called the transfer effectiveness ratio. And to explain that in a little bit more detail, a transfer effectiveness ratio of 1 means that your virtual world actually equates to the real world. And so our TER was 0.79, which basically came to the fact that if you do 60 minutes of VR in our platform, it can actually substitute for 48 minutes of that same experience in the actual operating room. Next slide, please. So this is a famous slide by Gallagher in my last 2 slides. Gallagher, if anybody's interested in simulation, this book called Fundamentals of Surgical Simulations is a must read. So on the right is a traditional learning curve for physicians, in this case, surgeons. When you introduce this idea of proficiency-based learning or learning based on data or metrics and deliberate practice, you can actually impact the learning curve. So imagine having 2 physicians on 2 different learning curves, but one is learning accelerated at the same pace or perhaps faster than the other physician. I think the world we live in with this time, convenience, and efficiency, this is something that we all need to look at in much more detail. Next slide, please. So, this is an animated slide, which may or may not come up, but really, in our opinion, there is a role for virtual reality in medical education and surgical education. And the other modalities we've used are equally as important. They provide an adjunct. VR should not live in a vacuum. It must go along, as Dr. Sherman mentioned, with a curriculum. You need to have mentors who are interested in teaching, and you have to have ideas and lectures and videos which go along to help accelerate and push people's potential. And it has to embody this idea of productive failure. And with that, I'll conclude, and thank you very much for your attention.
All right, thank you, everybody. And with that, I'm actually going to ask all the speakers to leave your seats and come and join us standing up here in the stage area, because this is the point where this gets interesting when we go into the question and answer session. So the rules for how to do question and answer are up on the center screen right now. And basically the way that it will work is, oh wait, are we missing somebody? Where's Sam? Sam's coming up in the audience too, right? How are you, Sam? well, we'll let him join. But Sam from Level X said he was going to join us in the audience as well. So with that, if you would like to ask a question, the only thing I will ask is, once again, please raise your hand. I will call on you. The way to raise your hand is in the center of your screen. The center of your button on the Virbella screen at the bottom is a raise hand button. I will call on you. Wait for me to call on you, and then you can unmute your microphone, at which point you can talk, basically, and ask your question. Then please re-mute yourself. And once you are muted, we'll throw it to whichever panel member you wanted to ask the question to. For those of you who are watching on Facebook, feel free to please type any questions in the Facebook chat. We'll try and take things as we get them in order, but if I see a question come across on Facebook chat, I will read it out in the room. So again, those of you who can't make it into Virbella and are watching on the Facebook chat, you guys are free to participate as well. And with that, let's see who the first person is with a question. Who's going to be the brave one here? I'm looking for a hand to go up. Angela Torrey.
Hello.
Hello, Angela. Go ahead.
Hi. Okay, so I'm a recent graduate from DePaul University, and I really am interested in immersive technologies within the healthcare industry. And I would love to hear suggestions or any recommendations on my learning journey, and specifically how I can get into this industry. I have a healthcare background, but I really want to get into either consulting or business development. And that's it.
All right, so Angela, go ahead and put your hand down and mute yourself. And I will, I'm actually going to, since you're asking about how to get into the space and working, and I know we have people actively recruiting here, I think I'll toss that one to Eric potentially first.
Yeah, sure. Thanks so much. We honestly, a lot of opportunities, there's a lot of companies that are obviously in this space that are hiring, especially when COVID hit. I think it's shown a lot of inefficiencies in a lot of the healthcare education and the patient education space that were always there, but really COVID's shown a really bright light on it. And so everybody's sort of scrambling. We've gotten a ton of interest from anybody who's trying to do anything virtually. And this has made a huge difference in our business. And, it's enabled us to hire. We've hired, I think, almost 30 people just during the pandemic. I think we have, I don't know, JP's here, so he can keep me honest. But we still have, I think 15 to 20 positions that are still open. So we're always looking for hiring. We actually take interns now, which we hadn't in the past. And I don't know if anybody else is hiring interns right now, but just try to volunteer, not necessarily volunteer time, but try to reach out to companies. I think a lot of people are open to getting people right now. And especially what's enabled us is we've gone completely virtual. So there was a big barrier for people who didn't want to move to Chicago or work in Chicago. That's gone now because everybody's working remote. And I think that gives you a huge opportunity to get positions across the country, not just in Chicago.
Anyone else on the panel that wants to just sort of toss an opinion on that one, please feel free.
Yeah, I think I could weigh in on that one. So I have a master's degree in biomedical engineering and definitely didn't see myself ending up in the video game industry. But, you just keep your eyes open and get plugged in with organizations like this. It's a overused term, but this is the networking, right? Talk to people in the crowd that may have opportunities, maybe looking for somebody with your skill set, and just keep plugging away and keep looking for companies doing innovative things like all the speakers had up here.
All right. Devinder. See that you're unmuted, Devinder, but I still can't hear you. Still not hearing you. You can try typing your question into the chat as well, if you would like to. With that, we do have a couple questions coming in from Facebook. So let's go with Can the panel please speak to the funding sources and market for these technologies in the medical education space? And I'm actually going to start down the line on this one. So let's go with, I'll start with Mike, actually.
Yeah, absolutely. So we've had the benefit of having a significant amount of funding from the Canadian government. So in Canada, we have this great program called the IRAP program, which is from the National Research Council, which funds research and development projects. We've also had some funding from provincial governments, and then we also have bootstrapped our company. So, you know, a lot of our funding comes from just contract work and work with our platform, sales sort of on our platforms. But yeah, in terms of government funding in Canada, we're pretty lucky. And I'll leave it there.
Danny, you want to add to that?
Yeah, thank you. I would agree with that. Obviously, being in Vancouver, Canada, we explored a similar program. We also have received some grants for some of the research that we've done based on the submissions to obtain and carry out some research. The other thing we did early on is we did actually fundraise. So we went ahead and fundraised with one of the largest medical organizations in the world that train orthopedic surgeons. So they're referred to as the AO Foundation. And they invested just over $2 million into our company back about a year and a half ago, which obviously provided significant assistance to our current status.
I'll speak also on that. So we, I think we should move to Canada. That's part of it. But we started at Matter. Actually, we were a venture-backed company, and we've explored, obviously different business models. But grants and societies are abound, especially now. People looking for technology solutions for a lot of different problems, and VR especially has so many areas, including VR therapeutics and pain and all these different areas. I think there's a lot of grants and opportunities that are coming up. There's a lot of innovation hubs. Those are plus minus. I think some of them are really good and some of them are not. So I think those are other areas to explore, or tech accelerators, things like that.
I'll say from my vantage point, what we've used is NIH mechanism. I mean, it's tough, like SBIR versus the R01 mechanism. But going forward with what we're planning with Rockefeller Neuroscience Institute is really going to be grateful donors and developing through giving, as we, because that's what's worked in the past with their other initiatives. So I think that's going to probably be our best bet. And also working with companies that want to share cost of development. So, we do have an underlying budget. So some of that, looking for companies that we can kind of share a developmental cost would be of interest.
All right, Tim, you want to jump in on this one, or do we want to keep moving?
Yeah, I would just say that we spent the last year and a half going after grants, and we submitted probably, I would say, 5 or 6 in the last year and a half, and they've all been scored. We just received one from the National Science Foundation, and that was PIR. So we're in the middle of that one now, and it's a phase 1. So we're thinking we might also be doing some work with the DoD and potentially NIH, just given the feedback we've had. And since COVID, I've been absolutely incredibly impressed. You think of these as black boxes. Having been in the government and the DoD, I did not anticipate this kind of interaction, and I've been very impressed. So folks want these innovations out there. They're willing to work with you to understand what you can bring to the table, and they want to see big shots on target and people to swing for the fences, and that's to all of our benefit as long as it is evidence based. So I'm very impressed so far.
Excellent. Okay, so Devinder's question, he typed it in for us, so we're going to go back to it. And it's specific for Dr. Sherman. Can you speak to the 3D model creation process for the tumor of the brain?
Yeah, so it's interesting because there's other companies that provide this, and I looked into those as well. This is that's the proprietary technology that they use through surgical theater. I will tell you that their technology is very tech heavy. meaning that, part of the reason it's expensive to get them on your campus is because you have to hire a tech that's there full time. And so it's not something that I mean, I could figure it out, but when we were trying to get, like, for instance, like the brain itself, you want to actually make it look like the brain, the color, not just the color, but the texture, and kind of have those, the subtleties to it. And so we had to work with our MRI people to, pick different, we call it, there's a Fiesta sequence, there's an SPGR, so there's all these different sequences. So we had to work with them to try to create the best sequence so we could then generate the brain. But then if you go through the brain, it's actually still quite pixelated. So one of the goals, and if depending on, if you want to use the fiber tracks, we'll incorporate diffuser tensor imaging, which looks at those fiber tracks, and also functional imaging. But like what I had in that video is actually looks like a blob. We actually linked with a different company that then linked with Surgical Theater that actually provides better fiber tracks. But it's very tech heavy. So, they can actually take a fine cut MRI. So you have your standard MRI that you come in. That if it's just a base one, you go to any MRI center, probably isn't fine cut enough. So that's why, because the patient I gave the example of, they come back and I order it and they come for a second visit. They can create it in 10 minutes, but they know how to do that. So we work out a system where the patient comes in, the tech is I'm already telling them what to set up. We build a relationship, they build up the model, and then they're coming in with me and they're, and I'm showing them based on the setup. It makes a clinic visit not be 2 hours. It actually can make a normal setup. But to answer your question, like, you really need the right imaging. You need to work with your technologists. You need to work with your MRI and CT people. And so if you want to maximize, like any technology, if you want to maximize it, you got to spend time sitting down and really figuring out what you really want to get out of it and what you want your patients to get out of it too.
Okay, we have like a whole string of questions from Facebook, so I'm going to start going through them really quickly. So this one's from Amita. What challenges do you face when trying to get VR surgical training curriculum included in medical programs, and how are you overcoming those challenges?
I can speak to that just from GW's experience. The biggest problem I had was interest. So I wanted to have a whole curriculum based on, in the medical school. And so when I brought it up to our deans, the first thing that came up to them was, LCCM guidelines, how much work is this going to be? And they just weren't all that interested. And so I had to, they'd say dumb it down. And essentially I went to the anatomy school, and it took 2 years to even bring that 3D Organon company in, because I had to go to the PA program because they had a lot less restrictions. So that turned out to be our pilot, only because I couldn't get the dean of medicine to get excited about it. So I found it very challenging to try to get them to think of a new technology and work into education, because then you have to also make sure, if you're doing a test where you have a group using it, a group not using it, you have to make sure it's fair so that it doesn't negatively impact the training of those who aren't using it. So it gets a little challenging on what I found.
Anyone else want to weigh in on that as well? Okay. Before I know Devendra, you had another question, but there's a couple that came in from Facebook ahead of you. So this one is from Alex. Where do you see the technology headed in the patient interaction space in the next 5 to 10 years? I'm not going to call on you guys. I'm just going to let you. Whoever wants to take it, go ahead and take it first.
I will. I'll do one quickly here. So we, as I mentioned before, we did quite a bit of VR initially, which was primarily, believe it or not, interactive 360 video to help folks understand treatment options, to show them patient stories in a way that, of course, was engaging more of the brain, but we could also act upon using interactivity and analyzing how they were navigating those rabbit holes. But what we're understanding now is, well, there's a huge gap here in the folks who do see our content and make a decision, and we should be able to follow up with them. And following up means training. It means supporting them remotely. It means leveraging all possible devices to ensure that they have the tools they need and the support they need, because we cannot always have a nurse or some staffed model in the home. So we are now, and I'm going to be learning from some of these folks on stage and these companies here represented in some of the literature, how to go about adapting these training models to patients. So I think over time we'll see beyond VR, we are certainly already testing some AR-based models and in very different subjects than we've been before. So I am interested to see how we progress from one medium to the other. But beyond that, I'm sure there's plenty of haptics level interaction with some of the companies that are on the recently IPO'd here in our space at least. And we know that that's a pretty interesting topic and quite relevant for the patients.
Yeah, I think one of the things we're thinking about at WVU as we're really developing our infrastructure is how what's our clinical problems, because I think that's the important thing, not just trying to integrate VR just because we want to integrate VR and AR, but what's our clinical problems and what's the best way for our patients to experience those. And I think as we develop that, we'll and as we go forward, we'll see that some applications are better in the VR space. Some applications are much better in the AR space, and then some of it are you actually need a mixed reality to actually interact with your environment and stuff. So I think that's going to be the key as it moves forward is finding clinical use as you find clinical uses in the healthcare space, making sure that you're not just trying to fit a square peg in a round hole, but actually maximizing the technology for what the patient experience needs to be.
And I can bid on that too. I think both of them sort of hit on this, but haptics is the holy grail. So if we're looking at medical education training, I think we obviously interacting with a controller that isn't the actual device you're going to be operating with does add some cognitive load. You have to focus on doing things that are unnatural in order to learn, and that always can detract from the actual learning. So when we get actual devices that are either 3D printed or give us better force feedback and feeling, because surgeons operate with all of their senses. We operate with smell. We operate besides taste. I wouldn't recommend that. But we operate with a lot of different senses, and not having force feedback and not having feeling and palpation does limit a little bit of that technology. And I think haptics is the holy grail. I'm not sure if we're going to get there in the next 5 years. There's been a lot of interest in haptics, but we'll see what happens. And the other is that the hardware has to get down to consumer grade, where everybody can have it like a smartphone. And I think that will definitely enable a lot more technology solutions to be in the homes, as opposed to, again, being locked behind closed doors or being too expensive. And it's starting to get there. Obviously, the VR headsets have dropped dramatically. And obviously now having mobile AR does open up a lot of worlds, and web-based AR opens up a lot of worlds.
If I can add to that comment as well, Eric, I think the haptics discussion is very, very interesting. And haptics is something that, at least I can comment on the orthopedic space. So we're looking at this in detail, but I'll share a study with you that was actually done maybe about 10 years ago at the University of Toronto. What they did there is, so let me give you some background. So when you drill through bone, for example, when you drill through hard bone versus softer bone, the sound of the drill changes. And when we teach that skill to residents, we actually have them listen for that sound, because that'll impact how hard or soft you're pushing. So when they muffled that sound, for expert surgeons, those surgeons actually had lost their expertise in drilling with accuracy. And so that idea is referred to as synesthesia. So we think that, at least in orthopedics, there's probably a critical time where you need to introduce touch, but then that touch idea actually disappears. And what you really rely on is sound, as well as the visual field that you're looking at. So it's a very complex area, and we don't know the answer to it in orthopedics. It does play a role. We just don't know if the ratio needs to be 1-to-1, or if it can be something lower than that, moving into more expertise.
Speaking of ortho, I had an interesting conversation with Justin Barad with OSO VR, because he was saying about haptics is that he would get complimented for the haptics in their simulators. And he actually said, they didn't really put any haptics in the simulators. It was just the visual of hammering and the reverberation just from the Oculus handle actually made it feel like they were haptics. And so, the real question of how important haptics is in these simulations is, I think, still unknown.
All right. We have another question for, this is again from Facebook. I will get to yours, Devinder. Sorry, a lot of people from Facebook beat you on this one. Is there a way to introduce this type of learning into the lower resource schools on the west side of Chicago? It seems like very expensive technology for grade school and high school students. How do we get stuff like this funded?
So I can speak to an initiative that we're involved with. So this has to do with low middle income countries in Asia and Africa. And we actually were able to receive a grant from a mega grant from Unreal, which is the game engine that we use to build our content. And that grant allowed us to, working on now is building content for this organization called Sign Fracture Care. And to give you some background on them, which is they're an organization I admire a lot, is the orthopedic surgeon there and his team, they actually travel to Africa and Asia and these low middle income countries where the average income is $2 a day to actually train the physicians how to do nails in broken limbs, so femurs and tibias, which is quite common in the working class. Now, they don't have x-rays there, so the reason that the importance of being able to go there and teach them how to do this skill is extremely important, because you can actually, make somebody worse, or if you don't treat them at all, the whole entire family goes into deeper poverty. So I think there are initiatives out there that help support developers like us and others to help provide this content at lower cost. And, Oculus just lowered the price of the headset. So I think the hardware will get less and less expensive, and the content will be able to be generated much quicker. So I think there is opportunities to provide this to low middle income or different parts of the world or different parts of the country.
Okay. Last one from Facebook. This is a really interesting one, and then I'll get back to Devinder's second question. So Francis from Facebook is asking, the speakers have presented a lot about educational, using immersive technology for education, but is anyone looking into doing it for potential experimental surgical procedures or treatment plans, or developing new procedures? And if so, how would you proceed in that regard?
Doing for surgical plans. I mean, I use it all the time for planning out, and that's what I was saying in my talk. I don't know if I really said it right, but you're practicing all these cases in your head, and now I can, with the patient's own anatomy, plan out a procedure. And I feel in certain situations it's actually an improved surgical experience because I'm prepared better for things that I might not have otherwise seen. I mean, I'd be interested if the other panelists say about new procedures, because a lot of the development is based on what's out there. So you take a procedure, you film it however you want to do it, and you develop your simulation. So to take a new type of procedure, I would, maybe Danny would have a good insight on this, on how you would do that from a simulation perspective without ever having seen the procedure in real life.
Yeah, that's a complicated answer. I'd have to give that some thought, actually.
I will say, obviously surgical planning is a huge area, and the stuff that Jonathan showed you, we do it in sinus surgery. So there's actually one of my colleagues in New York that does surgical planning. So it's like very difficult surgery so that you can actually see your approach, and that's really what Jonathan talked about. Also, there's been surgeons, especially in Europe, that using AR overlays onto actual procedures. So if they're doing a liver resection, they can actually see the bile ducts and the vessels in the liver as they actually resect it. So I think in-op AR does offer some interesting insights as you're actually operating. Now, registration, everything gets a little bit wonky, a little bit difficult when you're actually operating and manipulating the tissues that it's based on. But there's these interesting areas to explore.
Hey, Matt, are you muted?
Matt left after listening to me.
I just realized I said that I just realized I gave this kind of entire speech while on mute, so that was great. So I did want to say thanks to Mike, because I know he's got to leave, so if anyone wants to connect with him, his information is up on the webpage. But with that, I want to get back to the last question that Devendra asked, which is kind of for all of you. We'll just really quickly go down the line. What kind of ROI are you seeing from these types of initiatives? Mike, if you want to jump on that one really quick before you got to go. No? Okay.
Well, I can say personally from the return of investment, it's a labor of love, to be honest, because what I've realized in this space is you have people either get it or they don't. And and I've realized, at least after doing this for 5 years, there's really no point in trying to convince people they don't get it. And that was really evident when I was doing the working group and trying to get other people excited about this space when I was at GW. So the return on investment is great when it finally comes through, but it's not like surgery where you have an immediate high from a great outcome. It's more like basic science research where it's years of development. And so the return on investment is constant through the little wins, but they're little wins with a long goal in mind. And I think you just got to be patient.
Danny, you want to add to that?
Yeah, so we did a financial analysis on our last study, which was comparing, flying to a course versus doing the same procedure in VR and then assessing a learning outcome. So ROIs can take multiple forms. The most obvious one is the investment part. But when you're talking in the education space, learning outcomes is an ROI. And so if you can demonstrate that your technology actually has tangible learning outcomes, that is something people will listen to and stop and pause and give you the attention you need for your product. And I would say that's a first big step. A lot of this is a very exciting technology, but we do have to prove that it works. And that requires high quality research done in an unbiased fashion to actually prove that learning outcome ROI before you get the financial ROI.
Excellent. Tim, you want to add to it?
Yeah, quickly, I completely agree with Danny and Dr. Sherman here. For us, it has a lot to do with what I would compare to clinical decision support. So if we're helping patients make certain decisions about their care, we want to know how VR as a delivery mechanism compares against the traditional learning mechanism. So it is very much about learning outcomes, as Danny pointed out. And certainly once we know how that impact looks, we have a pretty good idea of the economic side. And for context, we've been doing this for over 2 years now and still just getting our arms around what the ramifications mean in this new healthcare industry, in particular in our space, but very much learning outcomes driven for now.
Yeah, and unlike orthopedics, neurosurgery is notoriously bad at it's showing that the virtual success translates to surgical success in the real world. So it's not been, the literature has shown that it's not been very successful so far. As much so as you've seen in orthopedics. So that's still a challenge for us.
Eric and Sam, you guys want to add to it real quick?
Yeah, I was just going to say, everybody sort of talked about it. Research is hard to really prove out in the way that at least educational research says that, you have to prove that learning's happening, that behavior happens from that learning, that patient outcomes are improved, and that patient outcomes are improved, that there's a return on investment when you're looking at it from that standpoint. I think there's definitely things that, some of the panelists here have shown some great research that shows that there is improvement. Sometimes we do non-inferiority studies in education because we know there's a cost savings. So if you can actually get somebody to not have to buy cadavers, for example, or you can get somebody to train at home or on their own time, I think that's a definite return on investment. But patient outcomes are very, very difficult to show a difference and tie it to one variable. Those studies are extremely difficult, as you can imagine, and getting ROI on that is extremely difficult. I think everybody strives for that, and I think everybody takes steps towards that. But I think some of the panelists here have done some phenomenal research, and I applaud them.
All right, and with that, we're gonna kind of wrap it up here and get back to networking so that people can actually have some one-on-one conversations or some smaller group conversations here. The one thing I want to add, actually, because our topic for the day has been healthcare, and this has been a very, very tight focus on kind of medical and almost even very tight around surgical. But the one thing I want to say is Eric touched on a little bit. It's all, when it comes down to it, it's about the better outcome for the patients. And one of the things that we've been working on with Bundle AR comes down to sending patients home from the doctor's visit or from a post-op or something like that with information about like what you're supposed to do afterwards. What's the post-care? And what we're doing from an augmented reality perspective is pretty simple. It's literally just we're augmenting the brochure. We're augmenting the piece of paper that you get that says, okay, here's what you should do next. which I don't know how many of you have been through, some sort of surgery or some sort of procedure where you get, a 15-page single space typed document that's, okay, here's everything you're supposed to do for the next 4 weeks and not supposed to do and how you're supposed to take care of yourself. Or a brochure on postoperative care. And it's like, it would be really nice if you had something, again, that's a little bit more engaging, a little bit more fun, a little bit more immersive, and honestly, a little bit more quick reference. So versus having to kind of like look through a whole lot of text, something where you can maybe very quickly access a video or very quickly access a web link that brings you to more information. The other stuff that we didn't see a whole lot of in this particular event, but we can talk about, and I know we spoke about it on the kind of promotion for this event, is simple things like just the health benefits of playing Beat Saber and getting exercise, or even some of the meditation spaces that are taking place in VR now that are consumer tech that everybody has access to. Like, this all speaks to healthcare. And especially, in the world that we're living in right now where everybody is separated and can't get away from things, it's useful. But with that, thank you. I do want to thank the panel. You guys, I can't tell you guys, like, Danny was in a surgery immediately before this. Originally, Eric was going to have to leave right after his speech. So thank you guys all very much for making the time to be here and actually present to our audience, both here in the space and on Facebook. And for anybody who's going to watch the stream after, because we've been noticing more and more that these videos are getting a lot of plays after the event. For anybody who does want to actually connect to these folks who are up here giving all this information, their information's on the VRARchicago.com webpage. They wouldn't be here if they didn't want you to connect with them and ask questions and reach out and find ways to use these solutions. Once again, I want to point out Level X. There's 3 people here from Level X because they have open positions. So if there's anybody in the audience that is looking for a job, Angela, I'm looking at you. If you're still here, these are people to talk to. And even if, maybe you're not a direct fit for them, they might know somebody that you would be a fit for. So with that, next month, we are going to be talking about education, which is always a hot topic when it comes to immersive technology. We've already got a lot of the panel put together. We're going to have a student on the stage this time around. So it's going to be a little bit, we're going to get a lot of different perspectives. And then in December, we're going to repeat a topic that, again, was very popular, which is esports and games. The other big news is either, we're hoping that by the November event, we are going to be able to give you guys the schedule for what's coming next year, because we're already planning, we're already working on partnerships, we're already working on, the one thing that, again, we found is very valuable for us and we've heard is very valuable for our audience here is, Matter partnered with us to bring some of these presenters tonight and to connect them with us, and they've obviously sent the word out to their audience as well. And so we're working on a lot more partnerships with a lot of other organizations to get them involved. Personally, I know for this one, we unfortunately got to it a little bit late in the game, so we couldn't get any direct involvement, but we did reach out to the American Medical Association and the Illinois State Medical Association to try and see if they can get some involvement here. And we're going to be doing that going forward with all of our events. We're reaching out to the communities that actually can benefit from this immersive technology. So with that, I will once again say thank you, and I'm going to shut up. Again, please reach out to the panelists, connect with everybody here. Feel free to connect with me if you have any questions or if you want an introduction. I'm happy to make an introduction to anybody in my network. For all of you who are currently sitting in desks, you're about to experience a little bit of a shock because I'm going to make the tables go away. And so what's going to happen is all the tables in the audience are going to disappear for a second, and I'm going to change them to a set of tables. And then what we're going to do after that is we're going to put what's called private volumes around those tables. So if you guys want to, kind of have, if it gets a little bit loud in the space and you want to have a quieter conversation with somebody, go to one of the tables. So right now, here we go. We're going to have no tables for a moment here. So everybody who is sitting is about to be standing. Yes, thank you. Please clap. Thanks to everybody here. And what I'm going to do now is I'm going to set up what are called conference tables. And I'm going to actually ask that level X, you were kind of sitting right by table B there. So I'm going to turn on private volumes. Jonathan Vlasic is going to be sitting on table B. If anyone wants to talk to him, he's raising his hand right now. He's right up in the front. And if anyone would like to talk to him about employment positions, he'll be at table B. For everybody else, once again, thank you. I'm going to stop the live stream in a few moments. But let me turn on those private volumes and everybody can turn on their mics. Thanks again.
Thanks, Matt.
Thank you, Sam. All right, I'm going to dance just because this was great.
John, I thought I'd introduce myself real quick. Hear me okay?
I just
and table. Let's catch up.
Hey, Matt.
Hello, who's that? Hey, Tom.
It's Tom. I need to get a flash drive for that gig tomorrow. You mind if, and Staples closes at 9. Is it a problem if I jump?
Hi, Angela.
All good?
Yep.
All right, cool, man. Sorry about that. Otherwise,
Yeah, no worries, no worries. Go, go, go. Thank you.
All right, peace.
Hey, John.